Now, how often does ADHD persist into adulthood? Excuse me, let me just have a drink of water and I'll explain. Studies indicate that about 70 to 80% or more of children diagnosed in childhood can be re-diagnosed in adolescence 10 years later with ADHD. So it's a highly persistent disorder over the first 10 years following diagnosis. And even the 20 to 30% who no longer qualify for the diagnosis have not necessarily become normal or typical. Most of them remain quite symptomatic, but they don't have enough symptoms to meet all of our criteria for diagnosis. And therefore, they fall kind of in a gray or shaded area, a borderline area of disorder, where they don't meet full criteria to be diagnosed, but they're not typical of other people their age either. They're highly symptomatic, but not necessarily diagnostic or diagnosable. Now, about 10% of teenagers can be said to have recovered from their disorder by that time. The remaining 20% or more are that symptomatic group I've just mentioned. By the time we reach young adulthood, let's say age 21 or so, we find that it depends on who you ask as to how prevalent the disorder continues to be, how much it persisted. So, for instance, if you now, instead of interviewing the parents of this person like you did when they were children, if you interview the adult with ADHD about themselves, notice that only about 3 to 8% of the individuals describe themselves with enough symptoms to meet the diagnostic criteria. In my study, we were using the DSM-3 back then. So we found that about 3 to 8% would qualify for the diagnosis. So if we relied only on the adult self-report, we would say that most people outgrow ADHD by adulthood. But of course, that's not true, because I told you earlier that ADHD limits self-awareness. So if I shift over to calling the parents back in and interviewing them again, as I did during the earlier childhood years of these children in my research, I would find that almost 10 times more of these people would qualify for the diagnosis based on their parents' report. That's a rather remarkable difference, isn't it? Say 4% if I interview the patient, but 46% if I call up their parents and talk to them. This illustrates the problem with self-awareness that I made earlier. People with ADHD may not think they have a disorder or that they're as symptomatic or as impaired as they really are. As a result, we don't want to put too much emphasis or importance on their reports of their own symptoms, but we need to interview others who know them well. Now, there's also a problem with the DSM I can illustrate here for you. The DSM symptoms, even in the DSM-5, were initially based on research on children, back in the days when we didn't think adults could have this disorder, that most children might outgrow it. So there was an emphasis in writing the symptoms, in determining the language, that it be applicable to children. I think you can see where that would cause a problem, because now if we try to use those symptoms to evaluate an adult, we're using symptoms more characteristic of a child. And of course, many people may outgrow the child version of the symptoms, yet continue to have the disorder into adulthood. So to illustrate this problem that people can outgrow the DSM symptoms, but not really outgrow their disorder, look at the next number here, the 66%. That's how many children in my study would qualify as having ADHD if I used a developmental threshold, the 98th percentile in the population. In other words, are you as severe as 98% of people your age in what your parents say about you using these parent reports. That's a very severe threshold to use to label a disorder. But we wanted to make a point, and that is that even using a very rigorous, strenuous, restrictive criteria for diagnosis, 2/3 of the children in that study would meet that approach, that criteria for diagnosis. So the difference between the 46 and 66% is the problem with the DSM. That's how many children outgrew the DSM but didn't outgrow their disorder. So it's fair to say that about 2/3 or more of children with ADHD will fully qualify for the disorder when they reach adulthood. And even more of them remain impaired in various life activities, such as in self-care, family functioning, relationships with peers and others, marital functioning, and especially educational and occupational functioning. So even if people outgrow enough symptoms that they can't be diagnosed with the disorder, they still may be experiencing some impairment or harm from those symptoms and from having grown up with the disorder. By age 27, in my own research, this was a group of children I followed to about age 27 to 32, we found that fully 14% could be said to have recovered from the disorder by both their report and their parents' report. So a very strict definition. If I loosen up the definition of recovery so that one or the other person said you had recovered, it might be as high as 35% could be said to have normalized or recovered from their disorder. But notice that the remainder, 2/3 or more of these individuals, remained fully symptomatic and even continued to meet the diagnostic criteria for the disorder. So that is why we say that ADHD is a highly persistent disorder into adulthood, where symptoms may persist enough to produce impairment in life activities, even if the person is outgrowing the DSM criteria that were largely developed for use with children. Now, the adverse consequences that we see accruing to people with ADHD across the lifespan can be summarized here. There are thousands of studies on these impairments and risks. Not all people with ADHD experience every one of these problems, of course not. But they are more likely to experience harm in these areas of functioning than are other people of the same age. Time doesn't permit me to go into great detail about these various risks and outcomes. This is, after all, just an introduction or an overview of the disorder. But let's take a look at the variety, at the diversity of harms that can happen if you grow up with ADHD. One, of course, is that it will impact adversely your school functioning. Over 90% of people with ADHD in childhood are doing poorly at school because of their symptoms. It is the number one domain of impairment that we see ADHD causing. Of course, there's lots of conflict within the family. That is true of most families with ADHD in their children, especially if the child goes on to develop oppositional defiant disorder, as many ADHD children are likely to do within a few years of the onset of their ADHD. Of course, as children begin to interact with other children in the community, their ADHD symptoms interfere with their relationships, resulting in them having fewer friends or even no friends and being rejected by the more typical peer group. 50% of children with ADHD have no close friends by second grade in school. And that figure is even higher if the child also now has oppositional defiant disorder or conduct disorder. Now, conduct disorder is a pattern of antisocial behavior, such as lying, stealing, fighting, and later on maybe even carrying a weapon or confronting victims. You might think of it as delinquency or criminal conduct, but in the DSM, it's called conduct disorder. About 1 in 4 ADHD children, at a minimum, is likely to further develop into conduct disorder. About 40% are likely to engage in antisocial behavior even if they don't meet all the requirements for a diagnosis of a conduct disorder. We know that this group of children who moves into antisocial activities are also the group most likely to experiment with, use to excess, and even abuse legal and illegal substances. So they may smoke more often than others, tobacco that is, which may lead them to try marijuana more often than others. We know that by adulthood they consume more alcohol than do others, and that they're more likely to become dependent or addicted to nicotine, to marijuana, or to alcohol by their adult years. And so they have a substance use disorder, abbreviated SUDS, SUDS, as you see on the slide. As they become sexually active, we find that children with ADHD are likely to start sexual activity earlier than others. They don't have any more sexual disorders or perversions than other people do, but they may start sexual intercourse at a younger age, probably related to their poor impulse control. And because they are more likely to start sexual activity earlier, and that they are more likely not to use contraception, and also that they change partners more often in their sexual relations. All of this leads us to discover in our research that people with ADHD are more likely, indeed 10 times more likely, to have a pregnancy during their teenage years than other children were likely to experience upon reaching adolescence and becoming sexually active. We also found that they were 4 times more likely to have had a sexually transmitted disease by the time they reached young adulthood. So, children with ADHD, as they reach adolescence, are more sexually active, more risk-taking, taking fewer precautions, and more likely to have had a child or contracted a disease from their sexual activity than are others. So this is something that families have to prepare for as their young people with ADHD become sexually active. As I mentioned earlier, accidental injuries are very common among people with ADHD. Indeed, children with ADHD are nearly twice as likely to die before the age of 10 from an accidental injury as are typical children. And adults with ADHD are nearly 5 times as likely to die by age 46 or midlife, primarily due to accidental injuries, than are typical adults by that age. After adolescence and into early adulthood, another cause of early mortality also occurs, and that is an increased likelihood of attempting suicide. Now, it's having depression with your ADHD that makes a teenager contemplate suicide. Think about it. But it's their impulsiveness that goes with their ADHD that makes them more likely to attempt and even succeed in suicide. So it's the combination of the ADHD impulsiveness with the possible development of depression that, when the two go together, greatly increases the likelihood of a suicide attempt. Yet another reason for early mortality in children and adults with ADHD. When they get their driver's license and start to operate a motor vehicle, we see that they do so in a very risk-taking, impulsive, and distracted manner. They speed more often with motor vehicles. They take more chances so that there's risk-taking involved. As a result, they have more crashes with the vehicle, and they receive more citations from the police as teenagers than other teenagers are likely to do. And these problems are likely to continue into adulthood. And by adulthood, when the increase in alcohol use occurs, we find that adults with ADHD are more likely also to have received a citation from the police for driving under the influence of alcohol, or abbreviated DUI on my slide here. As they leave school, they often leave with less education. Many of them may fail to complete their formal education, and certainly much fewer of them are likely to go on to college. Indeed, in our studies here in the United States, only about 5 to 10% of people with ADHD ever complete a college degree. Compare that to the 40% of adults in the U.S. who are likely to do so, and you can see that ADHD results in a marked reduction in the amount of years of education a person is likely to have obtained. This, of course, is going to have an impact on the person's occupational choices and their occupational functioning, and how much money they earn in life, and their financial difficulties. So it's not a surprise to learn that as ADHD children grow up, leave school, and go out into the workforce to try to earn a living and find a job, that they're going to have more difficulties in their work than other adults do. Complaints we hear from their supervisors are very similar to the complaints we heard from teachers when this person was in school. Can't finish their work, doesn't work independently very well, often is late for work, tries to take shortcuts in their work and not do as much as others, often shows much more emotion at work, inappropriate emotion. As a result, they're more likely to be dismissed from a job because of their impatience, anger, hostility, even aggression. Certainly they change jobs more often than other people do, about 3 times more often during any 10-year period. They will change jobs, and that is out of boredom, and they often quit impulsively before they even have another job lined up to go to. It's not uncommon to see a very checkered pattern of functioning in their work careers, that is, switching jobs frequently and not moving up the career ladder as quickly as other people do, because they simply don't stay with any given employer or occupation as long as others. So of course they earn a lot less money per year, about $12,000 less here in the U.S. They don't save up as much of their money as others, often having no or few savings in the bank. They often are very impulsive at using credit cards or borrowing money, and as a result they owe more money to others, and they often are likely to have a poorer credit rating with credit rating agencies than do other people. Now there are medical problems that occur over development that we begin to notice by adolescence and adulthood. One is that they have an increased risk for obesity. They're more prone to sedentary activities, to gaming, to streaming, to using technology, and to not paying as much attention to maintaining their health and their weight and their diet and nutrition as other people do. And so it's no surprise that twice as many of them will be obese by adolescence and adulthood. And of course, with obesity comes an increased risk for coronary heart disease, abbreviated CHD on my slide here. They're going to have increased problems with their blood cholesterol. They're going to be at an increased risk for type 2 diabetes. And of course, I already mentioned that they'll continue to have problems with accidental injuries and possibly even earlier mortality. There are many other risk factors I'll mention in just a moment that occur medically in the lives of people with ADHD, but this gives you the impression of yet another domain of impairment stacked on top of all these others that can occur to people growing up with ADHD. People with ADHD are less likely to get married, and if they do marry, they're more likely to separate or divorce from their partners. And when they are living with another adult, cohabiting, or in marriage, there's a greater likelihood of conflict and even interpartner violence within the relationship because of the problems with emotional self-regulation. And then as ADHD children grow up, have their own children, and become parents, if their ADHD has persisted into adulthood, we can show that it interferes with their parenting ability, with their care of their children. I hope you see that ADHD turns out to be one of the most impairing disorders we see in outpatient mental health clinics, far more impairing than depression, anxiety disorders, relationship problems, learning disabilities, and so forth. Very few disorders have such a wide array of adverse consequences across so many different domains of adult functioning than does ADHD. So I hope you appreciate the seriousness of this disorder if it goes untreated. Luckily, research has shown that with treatment with ADHD medications in particular, but also combining those medications with educational and psychological treatment programs, we can, in fact, markedly reduce the risks for most of these domains of impairment, provided that the patient remains within treatment and stays on medication, especially through the critical adolescent years, when many of these harms begin to become evident. So on the one hand, ADHD is a very impairing disorder when it goes untreated. On the other hand, ADHD is among the most treatable psychiatric disorders we know of, having numerous treatments that produce significant improvement not only in reducing their symptoms, but in reducing the risk they may have for experiencing these various harms or impairments. This slide is simply to show you in detail the various kinds of difficulties or impairments that can occur in each of the domains that I spoke about. I show it here only because I want it to be part of any handout that you might be given that goes with this presentation so that you can see the specific difficulties ADHD is likely to create. Many of these I've already mentioned. One that I alluded to or mentioned earlier is that ADHD might have an adverse effect on longevity, on life expectancy. Now, we already have established that it increases the likelihood of accidents and of early death by accidents in childhood and up to midlife. But what about after midlife? Do these problems that ADHD is causing lead to an accumulation of risk so that toward later life we see a shorter lifespan than we would see in others? And the answer is yes, we do. If you look at the third line of my slide here, you can see all of the things I've mentioned that ADHD was posing a risk for, from aggression to crime, to drug use, to violence, to a high risk of suicide. At some point, all of these, including their lower health status, have an effect on your life expectancy. These are the very things that insurance companies would use in order to calculate your estimated life expectancy. Since ADHD predisposes to problems in nearly all of them, it's not surprising we should see a reduction in total longevity. All of these behaviors I've mentioned are related to the personality trait called conscientiousness. Conscientiousness refers to, do you think about the consequences of your actions before you do them? Do you contemplate your longer-term welfare and use that to make decisions in your daily life. ADHD is associated with very low conscientiousness. So not surprising, ADHD would be expected to shorten your life expectancy. And we see that it does. As you can see here, I've already mentioned that ADHD is likely to pose twice the risk of early death in childhood, nearly 4.5 to 5 times the risk of early death in adulthood. But that's early death due to accident. Look down at the bottom of the slide, and you will see the results here of my own study, published a year ago, which was the first study to compute estimated life expectancy, given everything we know about ADHD children growing up. These results come from my own follow-up study in Wisconsin, in the United States, where we followed children for more than 20 years into adulthood, and we did complete physical exams and thorough psychiatric evaluations of them. And what we found is that if they had ADHD in childhood, even if they recovered from it by adulthood, their life expectancy was estimated to be about 9 to 10 years less than that of other children. But what happens if their ADHD did persist, that they could be re-diagnosed in adulthood with the same disorder, ADHD? The reduction in life expectancy was between 12 and 13 years. That's a lot. It may not sound like much to you, but ADHD has more of an effect detrimentally on life expectancy than most of the great public health concerns we have that shorten life expectancy. It's far worse than obesity, than smoking, than using alcohol to excess, and all of the other difficulties we've talked about, such as poor nutrition, limited sleep, and so on. All of them have a small but detectable effect on shortening our lifespan. ADHD is worse than all 5 of the big public health concerns combined. So that should, I think, lead to a very sobering impression that ADHD is a very serious disorder, and that it's not just a mental disorder or a psychiatric disorder or an educational disorder. It's a public health disorder, because it leads people to engage in choices in their daily life with regard to their health maintenance, and so on, their nutrition, their exercise, their dental care, their weight, and risk-taking, and substance use. It leads them to make poor choices across all of these and other domains, which eventually will add up to take a toll on their longevity, their life expectancy. So the answer to the question at the top of the slide is yes. ADHD does shorten life expectancy if it goes untreated into adulthood. Now, most people with ADHD have a second disorder. About 80% of them, in fact. Not only do they have ADHD, they have one or more of the disorders that you see on this slide. More than 50% have at least 2 of the other disorders that you see here. So it's very common in psychiatry to see that when a person has one disorder, it may link up and increase the risk for a second or third related disorder. In this case, as I've already mentioned, ADHD increases the risk for other impulse and emotional disorders, such as oppositional defiant disorder, conduct disorder or antisocial behavior, and eventual crime. Substance use disorders, which, as I said, go along with these other 2. Then, as I mentioned, a risk for depression. About 25% of ADHD children develop depression by adolescence. And if they're not depressed, by adulthood, nearly a third of them qualify for a milder form of depression called dysthymia, right? A small percentage, maybe 10 to 15%, may develop this new mood disorder known as disruptive mood dysregulation disorder that is a combination of very impulsive, aggressive behavior and destructive behavior with a pattern of irritable, depressed mood. We used to think that this was a form of bipolar or manic depressive disorder, but research now shows that it's its own separate mood disorder. Anxiety disorders occur in about 15 to 25% of ADHD children, but that figure doubles by adulthood to 40 to 50% if the adult went untreated during their adolescent and adult years. The longer ADHD goes untreated, the more likely an anxiety disorder can occur with it. A small percentage of ADHD children may be prone to tic disorders, even fewer to Tourette syndrome, certainly less than 3 to 5%. About 4 or 5% may develop obsessive compulsive behavior, although interestingly, as many as 10% in some studies may develop excessive hoarding as a problem. Autism spectrum disorder, as we see at the bottom here, is also a risk. 20 to 25% of ADHD children may qualify for this other neurodevelopmental disorder. And a small percent, perhaps 5 to 7%, may qualify for intellectual disability or what we used to call mental retardation. So the risk for these two disorders, other neurodevelopmental disorders, is not real high, but it's higher than you would see in the general population. One of the most common coexisting disorders with ADHD is a specific learning disability, a delay in one or more areas of academic achievement, such as reading, spelling, math, language, or handwriting. Over half of ADHD children will have a second disorder of specific learning disability, and more than half of them qualify for developmental coordination disorder. So poor is their motor development, coordination, and so on. We find that upwards of maybe 15% to 20% have some problem with language development and communication, particularly in the oral expression of language and the motor control of the oral musculature. Finally, we see that by adulthood, some people with ADHD, especially if they had conduct disorder by adolescence, go on to develop a risk for certain personality disorders. Among them is antisocial personality, what some people often think of as psychopathy. This occurs in about 20 to 25% of ADHD children by adulthood. A smaller percentage of them, maybe 10 to 15%, qualify as having borderline personality disorder. And then even fewer have what we call passive-aggressive personality. But again, what I want you to understand here is how impressive it is that ADHD individuals carry a very high risk for developing one or two or more other disorders. And often, the second and third disorder are going to affect the kinds of treatment that we provide them, and even affect the choices we make of ADHD treatments than we would expect to see in the general population. This is just a list, I've already gone over these with you, of each of those disorders and the frequency, that is the risk for which they are likely to occur in children with ADHD. I wanted you to be able to take this as part of the handout you might be given of these slides after watching this program. By the way, notice at the bottom of the slide that females growing up with ADHD are more likely to have an eating disorder. About 16% of them, in fact, had developed impulsive binge eating pathology or outright bulimia. They don't have an increased risk for anorexia, the more restrictive eating disorder that goes with perfectionism. Indeed, ADHD lowers the risk for anorexia below the risk seen in the general population. Why do we see ADHD individuals being at risk for these other disorders? A year ago, a large study of tens of thousands of people, of normal people, and of people with various psychiatric disorders, had their entire genome, that is, all of the known active genes in the human genome, were scanned, looking for genes that pose risk for various disorders. They then added up how many of those risk genes people got and whether or not those risks predicted other disorders besides the disorder that they had. So look here specifically at ADHD. Look at the bands that go to other disorders. The wider the band and the darker its color, the greater is the genetic relationship between those disorders. So that if you have ADHD, the genes that you have that are contributing to the risk for your disorder are also contributing to risks for, look here, anxiety disorder, down here, major depressive disorder, over here, post-traumatic stress disorder. And then because this color goes in the opposite direction, see this, it's negative, having ADHD genes decreases the risk for anorexia. Although, as I said, it does increase the risk for bulimia. Again, the point of this slide, especially for a layperson, is to show you that one reason that ADHD individuals are high risk for coexisting disorders is genetics. The genes for certain disorders are also genes for other disorders, elevating the likelihood that if you get one, you may get the other. Let's take a look momentarily at the causes, the etiologies of ADHD.